Hello, everyone.
Hello, everyone.
Hi. So it's a pleasure to meet you all. Welcome to this evening.
Yes,
It's a big pleasure
nice to meet you all.
to meet you all. So I welcome you once again for this SASSM e-school webinar series. I think
Yes,
there's an echo. Yeah. Can anyone mute the speakers? Somebody can mute the speaker. Okay, thanks. So once again, it's a pleasure to meet you all for this SASSM e-school webinar. And for this today, session, we are having Dr. Ka Lunlo from Hong Kong University of China and the monitor of KV. So we have been very happy to present you a different speaker, and this time we're having a pleasure with us. And so let's read a short CV for you all. We can please share this. Dr. Vinod has finished MBBS, MS surgery, and MCH in urology from the Government Medical College at Trivandrum. He works as a urologist and andrologist in Cure and SK Hospital and KJK Hospital and Fertility Research Center in Trivandrum. He is also the honorary treasurer of SASSM. He is a member of the Guidelines Panel on Male Infertility of USI, that is Urology Society of India, and he is also a member of Andrology and Men's Health subsection of USI. He has contributed in two books. He has contributed chapters in two books. One on the IMA book on infertility, and second on the male infertility in everyday practice. And he has been delivering talks at various national and international conferences on male infertility and in various years too. So it's a pleasure to introduce Dr. Vinod KV as moderator, and he'll be taking the show from here. Happy, sir. Please take it from here.
Thank you, Nitesh, for your good words and introduction. And I welcome all my dear friends and colleagues for this wonderful meeting. We all know the South Asian Society of Sexual Medicine, which is commonly or lovingly called as SASSM, has been conducting various learning activities in the South Asian region. And we are actually planning a lot of verb learning modules and e-learning methods to educate more and more people about men's health and sexual medicine and andrology, and giving a proper guidelines in the treatment of patients in andrology. And this is the first of its series of three webinars planned as part of the Men's Health Month. And today we will be discussing the problem of BPH, benign prostatic hyperplasia, and chronic prostatitis. We all know that prostatitis is a common problem seen by almost all urologists and andrologists. And this commonly starts in the young age and carries forward. And BPH starts by around 45 to 50 years of age, and that is also a major problem. So together, both of these constitute around more than 75% of the voiding problems of the male. So we are fortunate to have one of the well acclaimed expert in this field, Dr. Halun Lo from China, Hong Kong, to deliver his views and opinions on this topic. Can somebody please share the CV of Dr. Lo Ka Lu is a clinical assistant professor honorary in the Chinese University of Hong Kong and an associate consultant NTSC Urology Hospital Authority chairman, and is a chairman of the Asian Prostate Federation, which is doing a lot of verb learning and other activities in the management of prostate problems of the male. Please, next slide, please. And he has specialized in certain areas of regarding prostate. One is the bipolar enucleation of prostate. He transurethral water vapor therapy of prostate, transperineal prostate biopsy, transperineal fiducial gold markers implantation, transperineal hydrogel implantation, multiparametric MRI vesicle imaging reporting and data system, bladder tumor endoscopic submucosal dissection. These are the areas where he has specialized in the management of prostatic diseases. When you consider bipolar, he is the director of Benign Prostatic Hyperplasia Registry in New Territories East Cluster Hospitals in Hong Kong, and he has done a lot of live demonstration of bipolar in SAU Grand Round in 2018, and he has moderated a bipolar in SAU Grand Round in 2019, and has delivered a lot of lectures in conferences of Korea. Next, please. And when you consider Resume technology, which is a new upcoming technology in the management of BPH, he has introduced it in Hong Kong since 2020, and he performed this technology for high-risk patients under local anesthesia. He has delivered lectures in local conferences in this subject, especially the Hong Kong Endourology Workshop and Hong Kong Society of Endourology in 2020. Next, please. And in transperineal prostate biopsy, he has introduced a transperineal prostate biopsy fiducial gold markers implantation in Hong Kong, and he has organized as the director of Hong Kong first freehand transperineal prostate biopsy workshop in the 10th Hong Kong Urology Symposium in 2018. He has performed live demonstrations of transperineal freehand and MRI ultrasound guided prostate biopsy, and has delivered lectures in conferences of Korea. Next, please. In multiparametric MRI, he has introduced multiparametric MRI vesicle imaging reporting and data system in bladder tumor endoscopic submucosal dissection in Hong Kong. He has developed a computer database for patients receiving VRADs and bladder tumor enucleation for clinical auditing and research. He has delivered lectures in conferences of Korea, Philippines, China, Greece, Malaysia, and Hong Kong. And he has got many publications in the index journals, and he has been awarded so many honors like Urological Contribution Award, the Chinese Urological Association Annual Meeting in 2018, and the Best Poster Display Award by the Hospital Authority in the Hospital Authority Convention in 2019, and he has been selected in the merit team in the Hospital Authority Convention in 2019, and he has got the Video Presentation Award in the 17th Urological Association of Asia Congress, Malaysia, 2019. With this short introduction, I welcome Dr. Harlan Lu for his discussion on BPH and chronic prostatitis.
Thank you.
Over to
Thank you, Dr. Benign, for the very good introduction of myself. And also thanks, Dr. Benign, for the invitation and also all the organizing committee for the very kind arrangement. I think tonight is a very good performance status, and so that we can share our prostate disease. So may I have share my screen first? This is my screen. So screen first. This is my slides. So because of the COVID-19, we have a very good chance to stay in the internet and share our experience of the BPH and chronic prostatitis. So to start with, I have no conflict of interest to declare. So in this webinar, there's some highlights. I will talk about the key elements of differentiation between the BPH and also chronic prostatitis across different age groups of men. And also after differentiation between these two diseases, I will talk about the management of BPH and also chronic prostatitis. So before I start, I will talk about where is the prostate. Actually, the prostate is just below the bladder and above the urethra. With these symptoms and also obstruction, there will be a series of symptoms like storage or voiding symptoms. However, it's very difficult to differentiate between the BPH and also chronic prostatitis because they all share some of the very similar urinary tract symptoms. Now you can see that in male patient, if the patient complains of urinary tract symptoms, there will be a lot of diagnosis, including the distal ureteric stone, bladder tumor, urethral stricture, prostatitis, which are included in the acute or chronic type, foreign body inside urinary tract symptoms, and also with urinary tract infection, neurogenic bladder, detrusor underactivity, nocturia, and also with OAP. Finally, will be the benign prostatic obstruction. So it's very difficult to differentiate. However, they should have some age group difference. For BPH, it usually occur in more elderly people, while the chronic prostatitis may be a younger age group. To differentiate this, some of the good instrument is endoscopy. Now you can see that for the cystoscopy, show there's a very enlarged by loop and enlarged prostate, which is obstructing the urethral channel of the prostate, while the chronic prostatitis, usually the channel is patent. Now you can see that the preference of the BPH is different. With increasing reach, the preference of the BPH increase. Now you can see that with a very young age, less than 40, the preference is just only around 5%. However, when it starts to grow older, up to 50% of those patients around 50 years of age, and it's very easy to remember, up to 90 years of age, there will be 90% of the patient develop different urinary tract symptoms associated with BPH. How about the preference of the urinary tract symptoms in Hong Kong? Actually, it's very similar preference all over the world. Now you can see that if increasing trends, not only the preference, but also found that the moderate to severe symptoms will grow with the age. You can see that if the patient with older than 70 years of age, the severe and the moderate urinary tract symptoms grows as compared with younger age. And you know that if the patient do not treat their BPH, there will be problem that we associate with clinical progression. We associate with other symptoms or disease like bladder stones, recurrent urinary tract infection, hematuria, retention of urine, and also obstructive uropathy. At the same time, the International Prostate Symptom Score also worsen with time. Now you can see that if the patient untreated, there will be increasing trend of the incidence of the IPS worsening. At the same time, you can see that the BPH surgery or acute retention of urine also increase with age. So it's very important to differentiate between the BPH and also the chronic prostatitis because they are different treatment. So it's very important to differentiate. Otherwise, the patient will have a different treatment while there's no response, despite you have tried a lot of treatments already. At the same time, you can see that in Hong Kong, especially in other countries, there will be increasing moderate to severe lung tract symptoms with age. And also BPH is progression disease. If untreated, they will get worse. And pathological and pathophysiological between these diseases are also different. Firstly, for BPH, aging is very important, as shown in previous slides. At the same time, some of the studies already shown that testosterone will also associate with BPH. With those patients without testes, the chance of the BPH is really very slow as compared with those with normal testosterone level. At the same time, weight gain, also obesity, also increase with BPH. And for the age, usually the BPH will not start with very young age, different from that of chronic prostatitis, where the chronic prostatitis will start with a younger age. After age of 40, it starts to have some histological changes with enlarged prostate histologically. However, over years of age, there's not much symptoms. However, with age, usually above 60 years of age, usually around 50 or even more of those patients with lung tract symptoms are associated with BPH. Apart from BPH, they are also associated with some progression, associated with OAB if untreated. FI associated with associated with other complications, including acute retention of urine, obstructive uropathy, bladder stone, or also recurrent hematuria. Now you can see that the endoscopy show that already obstructed channels, so associated with a series of the lung tract symptoms. While the chronic prostatitis is different, because of the different pathology, it can be associated with bacterial type or a bacterial type. While for the chronic bacterial prostatitis, we need to rule out atypical pathogens such as chlamydia or also mycoplasma. And also, there's a chronic non-bacterial prostatitis is also the inflammation without any infection. So the clinical presentation sometimes is very difficult to differentiate. For the lung tract symptoms, for the BPH, is usually with obstructive and voiding symptoms, including hesitance, intermittence, wheezing, straining, sense of incomplete entering, while the storage symptoms are associated with the frequency, urgency, and nocturia. Honestly speaking, the BPH and also chronic prostatitis will share very similar lung tract symptoms, so that we need to have a further investigation or and also histories to differentiate between these two diseases. However, for a BPH, as I told that there is a complication, while the chronic prostatitis will be unlikely to have the retention, recurrent hematuria, bladder stone, or obstructive uropathy. And also for the chronic prostatitis, warding symptoms and also distracting symptoms are usually on and off, and usually present with polylocalized pain, usually around perineal region, and also associated with malaise or sometimes with some fever, but usually it's just only low-grade fever. And the symptom usually persists for at least 3 months. However, there is some period of relieving and getting worse, just like a wave on and off. And predominant symptoms of the chronic prostatitis are usually pain at various locations, including perineum, scrotum, penis, and also inner part of the neck, as well as also lung tract symptoms that share with the BPH. So according to the EAU guidelines, the following are more easy to be done in the non-urologist clinic to differentiate between the BPH and also chronic prostatitis, including the medical history, urine analysis, IPSS, DRE, PSA, fecal warning chart, and also bladder diary. I will elaborate more in the later slides. For IPSS, International Prostate Symptom Scores, it usually differentiate the symptoms into the mild, moderate, severe, with the questions that will be filled by the patients. For the mild, it's 0 to 7 points. For the moderate symptoms, it's 8 to 19 points. For the severe one, it's 20 to 35 points. So there's a Chinese version and also English version, depends on your nationality. So it's very important to differentiate the severity of the symptoms of the urinary tract symptoms. However, in this IPSS, it cannot be diagnostic to differentiate between these two diseases. For digital rectal examination, we can share with the prostate size, volume, and also shape, consistencies, whether there's any nodularity, hard nodule, at the same time to rule any prostate cancer. At the same time, for advanced prostate cancer, we also look for the laxity of the anal sphincter, which will signify the spinal cord compression due to advanced prostate. Apart from that, you can see that the prostate volume is also a very good indicator for the PPH progression. While you can see that the chronic prostatitis, usually the prostate size is not grow with time. While for the PPH, you can see that if the prostate more than 30 mil, you can see that the chance of the PPH progression will increase with this prostate volume. So it's one of the differentiate between these two diseases. And how about the PSA? And PSA usually used to differentiate whether there's a benign or prostate cancer. However, sometimes it's very difficult to differentiate between these two diseases because both of them can increase with PSA. And also, PSA level will also increase with age. At the same time, according to the prostate volume, prostate growth is also associated with increase in PSA. And also, you can see that for the increased PSA, sometimes we associate with the symptom or also bothersome urinary tract symptoms. And also, we associate with worsening of the flow rate. At the same time, some of the studies already shown that the elevation of the PSA also associated with the risk of the acute retention of urine and also risk for surgery, probably because of the increase in prostate volume. So a PSA is usually for to rule out any prostate cancer because you know that apart from the PPH and also chronic prostatitis, the prostate cancer can also share the urinary tract symptoms so that we cannot miss this very important diagnosis. So PSA can also with a very good tools, especially when the PSA is sky high, so that the high chance to be the chance of the prostate cancer. Then how about the prostate volume and the correlation with PSA? They usually associate with PPH because I saw that there's prostate volume increase with the PPH and also associated with increase in PSA at the same time with worsening of the urinary tract symptom. Now you can see that there's a very important chart to show that there's a very good differentiation between the PPH and chronic prostatitis. And at 75 years of age, you can see that there's a trend of the increasing of PSA, probably because of the enlarged prostate, while you can see that for 40 years of age, the prostate volume is not very large, so that the PSA serum PSA is not very high. So it's one of the two to differentiate these two diseases. And also, one of the study already shown that for a higher level of the PSA, associated with the PPH progression. While the chronic prostatitis, you can see that the PSA is not very high. It's different from that of PPH, and the PPH will also increase with the PSA. So if you test for the PSA, you can also predict there will be the PPH progression, while the chronic prostatitis, there is not very direct correlation in this area. So there are risk factors for the disease progression of the PPH. Firstly, is the advancing age, especially more than 60 years of age, and those patients with moderate to severe urinary tract symptoms, and also increase with the prostate volume more than 30 ml, at the same time with elevated PSA more than 1.5 unit. So another good tools to differentiate whether there's a PPH and also chronic prostatitis is that if the patient have the PPH, usually the urine flow is obstructive pattern. While the chronic prostatitis, if there's no obstruction, usually there will be very good flow as compared with the PPH. For a bladder scan, sometimes if the progression of the PPH, there will be large residual urine, while the chronic prostatitis, usually the bladder scan did not show any very large residual urine. If any doubt between these two diseases, especially there's some component of the urogenic bladder, Sometimes urodynamic studies can also differentiate between these two diseases. For the urodynamic study, it can differentiate the BPH with the obstructive pattern. You know that there's a BOI, and its unit more than 40. It signifies there's better outlet obstruction, while the chronic prostatitis usually the BOI is less than 20 or just only equivocal, and seldomly more than 40. If there's progression of the BPH, sometimes there are better contractility index will all be affected. Sometimes will be less than 100, which will have the problem of the hypocontractile bladder due to the chronic BPH. While the chronic prostatitis, usually the bladder contractility should be normal. Apart from that, you can see that the BPH associated with the other comorbidities, including the metabolic and also cardiovascular disease, including hypertension, chronic heart disease, so that if the patient presents with urinary tract symptoms, we bear in mind that we also have a consideration to roll this kind of comorbidities. While the chronic prostatitis is different from that of BPH, it is seldom associated with hypertension or other comorbidities. So in Hong Kong or also Asian country, there are also some studies showing that if the patient had correction of cardiovascular disease and also metabolic problem, the patient had also associated with improvement of the urinary tract symptoms. So that's why they will become hand in hand. So it will identify there's a risk factor of progression of the BPH. Sometime after correction, we can also have the improvement of the cardiovascular and also metabolic impact, probably because the patient have more health concern, have more exercise, have more diet control, so that to gain have more weight reduction. So is there any special test for chronic prostatitis? Yes, there's a STEMI test. There's a 4-class test. It's divided into two tests. Firstly is a first voided urine. This is the first set. This is particular, you can rule out there any urethritis. The second bottle is the midstream urine. Afterward, the patient can have the prostate massage. Sometimes they have a prostate secretion that can be saved for the culture. And finally, after the prostate massage, there will be urine that can be saved for the culture. So in total, there will be 4-class tests. This is called the STEMI test. I believe that many of us have known about this special test for the chronic prostatitis. So you can see that if there's a non-bacterial type, there's no negative pressure, there's negative culture. While there's bacterial type, you can see they can grow a very sensitive one. You can see I've shown that there's some atypical bacteria like mycoplasma and other specific bacteria, apart from the conventional bacteria like E. coli. So after diagnosis, you know that there's a different treatment between the BPH and also chronic prostatitis. Because you know that if you use the wrong treatment for the wrong diagnosis, probably the patient would not have respond with your treatment. So for the urinary tract symptoms associated with the BPH, it can be divided into conservative treatment, medical treatment, and also surgical treatment. If the patient did not have a very severe or moderate one, you can just watchful waiting. The kind of some behavioral and dietary modification, sometimes exercise, and also with some coffee and also tea restriction, the patient will have less frequency and urgency, and even can decrease the chance of lotteria. If you educate the patient to have a food restriction before sleep, usually we educate the patient have around 3 hours before sleep. However, we need to have maintain the total food intake, usually take more in the daytime. If the patient failed to respond with your conservative treatment, we need to consider medical treatment for the BPH. Very common treatment, including alpha blockers, 5-alpha reductase inhibitors, and 5 phosphatase inhibitors. This usually for those with warning symptoms. Apart from that, if the patient complaining a lot of warning symptoms, we also can consider some anticholinergic or beta-3 agonist. It is the combination of the voiding or also the storage symptom. We can also combination above medications. However, if the patient did not respond with the medical treatment or if there's any progression associated with PH, then we can consider surgical treatment. Conventionally, we can have a TURP or also transurethral incision of the prostate if the prostate is not very large. Now we have advancement of the many technology, including endoscopic enucleation of the prostate, laser, and also with open prostatectomy, which is usually now already replaced by the endoscopic enucleation. Nowadays, there are a lot of local treatments, including resume, ULIF, and also aquablation. However, there's a long-term efficacy is still under investigation. So there's a basic summary showing that if there is a patient with low interest symptoms associated with BPH, if there's no much bothersome symptoms, we can just choose watchful waiting with some education, lifestyle advice. If there is no risk of disease progression, you can just prescribe alpha blocker and also like Prostatic and other PDE5 inhibitor, usually for the voiding symptoms. However, with residual storage symptom, we can also add some anticholinergic or other beta-5 agonists. However, if there's any progression, you can also consider to give some 5-alpha reductase inhibitors, because study already shown that they will be very important drugs to decrease the progression, retention of urine, or surgery associated with the BPH, plus or minus the alpha blocker. If there's a lot of symptoms which is associated with storage, then you just prescribe the anticholinergic is good enough. So for the alpha blockers, is the mechanism is used to relax the smooth muscle of the prostate so that it can relax the prostate and also bladder neck, so as to open up the prostate channel and associate with the IPSS and also the urethral. Apart from that, the alpha blocker have very rapid relief of symptoms as compared with 500 repeated inhibitors. However, there's no associate with the effect on the prostate volume. There's no reduced long-term risk of acute retention of urine. At the same time, they will have no effect on the BPH-related surgery. And there is some side effects, especially some dizziness and also hypotension. And for the 5-alpha reductase inhibitors, it usually inhibit the conversion of the testosterone to dihydrotestosterone, so that it takes time for the progression for the decrease of the prostate volume. So the effect takes time, so it cannot have immediate effect as compared with alpha blocker, because it takes time for the inhibition of the testosterone to dihydrotestosterone. So with time, usually it takes at least 6 to 12 months for the prostate to decrease in size. However, after 2 to 4 years of treatment, there was significant improvement of the IPSS, decrease of the prostate volume, and also improvement of the Kmax. And most important is that it can reduce the risk of the acute retention of urine and also BPH-related surgery. However, there's a decrease around 50% of the serum PSA. So after 6 months later, with the Prostatic, you need to take the PSA. You need to take into account that there will be decrease at 50%, so that you can have consideration if the prostate biopsy, if there's more than PSA 2 as compared with PSA 4 without the Prostatic or other 5-alpha reductase inhibitors. Usually the side effect is just only well tolerated. Some of them just complain the erectile dysfunction, decreased libido, and also with some ejaculation disorder. With just only very rare cases have gynecomastia. However, there's no association with increased risk of cardiovascular disease in long term. How about the combination therapy? One of very landmark papers found that the DUDAC combination of the alpha reductase inhibitors and also 5-alpha inhibitors find that there's a significant superior symptom improvement as compared with watch waiting. Now you can see that there's a decrease of the IPSS with time. So combination therapy is one of the good choice, especially for positive volume more than 30 ml. And the safety profile of the DUDAC combination therapy is also well tolerated. And usually that's associated with just only mild symptoms, associated alpha blocker, and also the 5-alpha reductase inhibitors. However, there's no associated breast cancer. And also for the cardiovascular disease, actually there's not much associated factors. And there's no fatal side effect associated with the DUDAC groups. So you can see that if we have symptom progression, if we give the 5-alpha reductase and also with combination therapy, you can see that the PSA level decreased more than 50% after 6 months of age, after 6 months of treatment. So that we need to take into account when we need to have a PSA taken after 6 months of the treatment. So if the patient not respond with chronic with the medication and also with some progression of the PPH, so we need to consider surgical treatment. Here you can see that the EU guidelines already show that if the prostate is very large and the superior enucleation of the prostate is very effective surgical manner as compared with the open prostatectomy, it shared short and mid-term efficacy. However, there's more favorable perioperative safety as compared with the open prostatectomy. So apart from the bipolar, there's other laser enucleation, which is also show very effective safety profile and also improvement of the symptom as compared with the open prostatectomy. So it's advocate for those patients with large prostate, especially more than 80 grams. For the theory of the endoscopic enucleation, you can see that usually the PPH is enlargement of the transitional zone, which causes obstruction of the prostate channel. So our aim is to enucleate the transitional zone so that the peripheral zone also left behind. As compared with the radical prostatectomy for the prostate cancer, usually the peripheral zone also removed together with the capsule. So you can see that we can use the transurethral mean instead of the open technique. Here's the journal that I would like to share with you for those patients with required bipolar lab. And if the urologist and also surgeon want to start the bipolar lab, there's the video demonstrate how we can start our case. Usually we start with the early apical dissection. This is a very important steps because one of the important factors we need to consider is the urethral sphincter protection. You can see that the apical mucosa is very close to the urethral sphincter. Usually is over the anterior area from 3 o'clock to 9 o'clock anteriorly. So by early apical mucosa incision, you can see that we left behind a whole circumferential mucosa around the apex. So that is very important to separate the urethral sphincter from the apex of the prostate so that we can protect our urethral sphincter, and most of them can have urinary continence after the surgery. Afterwards, we start with the enucleation of the left loop from the apex to the basal area from the 6 o'clock to 12 o'clock. Why do we start with the left loop? Because usually we are right-handed, so it's more ergonomic. And then you can see that there's a dimple just proximal to remotenum. You can see that with correct plane, you don't need to have a very large force. If you use a very large force, probably you get into the wrong plane. Sometimes if you get a lot of power, there is a risk of the capsular perforation. So this is disastrous. Please be reminded that if you get into the correct plane, you don't need to have a very large force. Now you can see that if you get a very correct plane, the capsule is very smooth and there's not much bleeding. And usually the bleeding is just from the very major vessels from 2 o'clock, 10 o'clock, 5 o'clock, and 7 o'clock. Usually there's a name for that. Now you can see that there's big vessels over the 12 o'clock position. Now we are mainly using the Karl Storz thick loop one. this is autocomplete, which is the latest version. You can see that we can use the thick loop, which is a very large surface area, and usually the big vessels, which can effectively coagulate. Apart from that, the apical dissection, we need to go back of the anterior area again, because apart from the mucosa, we usually give a little bit of the apical loop left behind. The rationale behind is that we need to stay safe between the urethral sphincter and also apical loop. Sometimes the prostate is very large. There are very close relationship between the apical loop and also urethral sphincter. Now you can see that with intentionally we can left behind this so-called curtain. We can left behind the apical mucosa together with a little bit of apical loop, so that we can well protect the urethral sphincter. And usually the patient have a very good continence after the procedure. Afterwards, we can start with the right loop and equation, because we can open up the lateral plane from the left loop, so that you just follow the lateral plane from the left to the right side. The beauty of that is that you can save the time. You need to open up a new plane. You just continue with that of the left loop to the right loop. Now you can see that similar to the left loop, it's just a very smooth capsule. There is no irregularity mucosa as compared with the conventional TRP. This is one of the very important advantages, because you can see that you can save a lot of time for the hemostasis, because the surface is very smooth. After enucleation of the left and the right loop, sometimes you cannot identify the bent neck. So my trick is that we can resect a little bit of the bent neck down to the capsule, where we can join back the lateral capsule that we can already enucleate from behind. Now you can see that after the resection of 1 to 2 trips, we can identify the bent neck successfully. Afterwards, we can continue with the dissection of the bent neck circumferentially. Sometimes we can preserve a little bit bent neck, because some of the theory found that the urinary continence, we have some component over the bent neck. So if they're possible, sometimes we also preserve the bent neck. Now you can see that sometimes it's a very tough mucosa around the bent neck. Probably because there's a lateral attachment of the mucosa around the bent neck. I usually use both maneuver with sharp and blunt dissection, so that we can clear the bent neck circumferentially. With this thick loop, very large surface area, even though you can see that is a little bit vascular around the bent neck, usually with this thick loop, we can still maintain a very clear view all over the surgery. After enucleation of the bent neck, I think most of the enucleation finished. Now you can see that the enucleated part has been very mobile. I usually use the 1 loop technique, but for a beginner, we can just have the 2 loops or 3 loop technique. We can separate into the left loop, right loop, and also median loop separately, so that you can have a kind of improvement of your surgical performance. But once you get the experience, you can just unblock single loop and then fly into the urinary bladder. For step 7 is a very important and the most dangerous part. Now you can see there our nursing staff palpate the bladder continuously. We need to make sure that the bladder should be well distended. Now you can see that you use a very sharp macerator. You need to face the macerator towards a 12 o'clock position. Make sure that the bladder is well distended, otherwise there is a chance of the bladder perforation during procedure. If the macerated adenoma getting smaller, sometimes it's flying inside the urinary bladder, difficult to catch into the macerator. Sometimes we can just pour it back to the very patent prostate fossa and continue the left behind prostate adenoma. After the maceration, the final step is the hemostasis. But beforehand, we can already have a very good hemostasis. In this step, usually take around 5 minutes before we have a complete hemostasis. You can see that the urethral sphincter is well preserved at the end of the procedure. After full insertion, you can see that the efferent is very clear. So usually we don't need to have any bladder irrigation after the surgery. So I think the endoscopic enucleation is very good technique. However, not all the urologists start this technique probably because there are some barriers. Some of our study already shown that some problem is the mentorship. We believe that endoscopic enucleation is around 30 cases. There's a little bit steep learning curve, so that there's a mentorship is good enough to teach those with 30 cases before you can have independent to do the endoscopic enucleation. And some of the problem is the lack of the demonstrator, because if the prostate is very big, without a demonstrator, the efficacy to remove the prostate adenoma is very slow. At the same time, and also the instrument, particularly bipolar, and also the laser energy sources, sometimes it will be lack in some of the hospitals. And hopefully, with these barriers can be corrected, we can start our cases. So, what about the next novel treatments that I mentioned before? There's water vapor thermotherapy of the prostate cancer for prostate BPH. Apart from the conventional TRLP, there's a lot of local treatment for the BPH. We can also perform this kind of local treatment in the local anesthesia in the office-based manner. Usually can ablate obstructive channel, and also it also include those who have a median or also a large transient zone. We can have very large central zone. Sometimes we also can perform this water vapor therapy under local anesthesia, especially for those very high-risk patients. This is an 82 years old gentleman with multiple premorbid. Present to us is obstructive uropathy with a high-risk patient, ASA3, accompanied by the anesthetist as a very high risk of a spinal or general anesthesia. And trust volume is around 47 cc. Here is the trust sizing. You showing that's 47 cc. And the first step, you can see that we need to have a very good local anesthesia medication injection. We have the technique of the transperineal prostate biopsy, local anesthesia medication. We can use the long spinal needle to have a good hemostasis around the periprostatic region, so we have a very good control of the apical area. Afterwards, we need to inject more around the band neck area. Usually, we inject a very long spinal needle from the perineal area and then insert gradually into the bone efferents, where there's an angle between the semivascular and also the prostate. Now you can see that under the ultrasound guidance, make sure that there's a parallel between the ultrasound probe and also the needle. We gradually inject the local anesthesia medication, and kind of hydrodissection, and then gradually advance the needle gradually and develop the plane between the prostate and also the rectum. Now you can see that there's a injection gradually into the molar efferents, very deep inside the prostate. That's very important. Once we get a very good pain control, and the patients can have a very good static control, and the whole procedure can be performed around 5 to 10 minutes successfully without any movement of the patient. So that's why we can have performed this kind of resume procedure under the local anesthesia. After that, we start to insert this delivery device through the urethra. Mind you that it's very important not to injure any mucosa, otherwise there's some bleeding, which causes blockage of the wheel during the endoscopy. Particularly go into the open urethra and then gradually elevated the delivery device. Eventually, you can go into the vermontanum and to the bladder neck. You can see that the movement a little bit slow, so that do not cause any damage of the mucosa. Similar to the conventional TRLP, firstly, we can have a pan endoscopy to look for any bladder pathology, look for the bilateral ureteric orifice. Afterward, we need to measure the distance between the bladder neck and also vermontanum. And this is very important so that we can design how many cycles of the resume procedure, and each cycle should be have 1 centimeter away from the last cycle. And each cycle of the water vapor lasts 9 seconds. Now you can see that there's 2 centimeters between the bent neck and also the vermectinum. So we start with the first cycle. We start to retrieve back the delivery device from the bent neck 1 centimeter from the bent neck. This is very important so that not to injure the bent neck during this water vapor therapy. If the position corrected, then you can start to inject the water vapor. And we need to watch out if there are any leakage or water vapor. If there are a lot of water vapor leakage through the mucosa, we need to stop it and start into another place. Afterwards, we trip back to the 2 field of view, which is 1 centimeter from the last cycle. Bear in mind that we need to do all the cycles proximal to the vermectinum. This is very important not injure the urethral sphincter. So the landmark is the vermectinum. Bear in mind that all the cycles is proximal to this very good landmark. So after the correction of the place, we start the second cycles of the water vapor. You can see that there is a very clear wheel all over the procedure. There's not much bleeding, so they can see the correct area to start the cycle. In this case, there's no median loop, so that we just focus on the left loop. And similar to the right loop, this is 2 centimeters from the bent neck and also vermectinum. So in total, there's 2 cycles on the left side. And usually, the patient can discharge on the same day, like the conventional TRP, require better irrigation, and need to have stay 1 or 2 days more in the hospital. And this one is particularly good for those patients want to leave the hospital after surgery. And this is particularly important in this era of the COVID-19, so that the patient can stay at home, not stay long in the hospital. So it's one of the very good advantages over this local treatment. So we now start already cases of hospitalization with very high risk patient, and afterwards the patient also can discharge. And good news that there's no readmission to complication of this resume procedure. So usually, because it takes some time for the procedure to take place, usually it takes 2 days or a week. So in this procedure, we usually fully cover because the patient have some lung check symptoms. Most of them we just complain of some mild dysuria. So we after discharge, we also give some medication, including the antibiotics, because usually we need to treat any possible urinary tract infection. For lung tract symptoms like dysuria, we usually give some analgesic like NSAID, also give some pyridium. Because we take some time for the resume procedure to take action, usually we continue with our blocker, usually take 1 month more, and then we can titrate downwards so that usually the patient will free of medication 1 month after the procedure. Usually we stick to the protocol like 3 months, 12 months with post-op PSA, IPSS, OAPSS, IEF, and also we check for the transrectal ultrasound to look for any difference pre and post-op, and also we have document any improvement of the urine flow. And how about the treatment of chronic prostatitis? Usually not under any surgery for this treatment modality. And usually we need to have a kind of culture-guided antibiotic treatments. Usually depends on your locality, with some antibiotic resistance in some of the countries. So sometimes you need to consult your microbiologist. And usually we can give the quinine groups. However, there's an increased chance of the resistance of this group of antibiotic. So that's why the culture is very important. We need to give the patient according to culture sensitivities. But if there's not much particular atypical bacteria, Chrono so far is still the first line agent, which is recommended in the EU guidelines. At the same time, we also treat some lung tract symptoms associated with chronic prostatitis, like the NSAID, alpha blockers, pyridium, together with the antibiotics. If there's any atypical pathogens, we also need to consider any other antibiotics like doxycycline and also erythromycin. This group of particular good for those with chlamydia and also other genital mycoplasma. And how about the fragile? Vaginitis treatment is also indicated for those patients with vaginitis infection. As I told that, we need to monitor with some of the PSA because in 20% of those patients with chronic prostatitis, we also associate with elevated PSA. If there's elevated more than 4, sometimes we also need to rule out any prostate cancer. Particularly if the patient is more than 50 years of age, sometimes the symptom is very similar to those of chronic prostatitis, so we also need to rule other causes. Otherwise, the treatment may not have very good effect. One of the good monitor is the PSA. If the patient have treatment with antibiotics, sometimes the PSA level also decrease with time if the antibody is a very effective one. So the EU guideline also suggests a different duration of the therapy. For a chrono group, usually with 4 to 6 weeks, and different from the simple urinary tract symptoms. So 4 to 6 weeks are very good enough for those with chronic prostatitis. And for the doxycycline, it's usually 10 days for the chlamydia one or also mycoplasma one. As a fibromycin, it takes around 3 weeks for the traumatic infections. Vaginitis is 14 days for vaginitis infections. So you can also trace back this table in the EU guidelines. So before my end of this presentation, I would like to give you some take-home messages. Firstly, it's sometimes very difficult to differentiate between the BPH and also the chronic prostatitis because they share very similar tract symptoms. However, there's some age difference. For the BPH, usually grow with age, while the chronic prostatitis usually is a younger age group. And for the BPH, is a progressive disease, which untreated, there is progression like retention urine, requires surgery, and also there is impact over the quality of life to the patient and also with his partner. And for those patients with BPH with moderate to severe urinary tract symptoms, prostate volume more than 30 mils, and also PSA more than 1.5 nanogram per mil, there is risk factors for the BPH progression. While the chronic prostatitis do not this kind of risk factors for progression, if the patient have risk of progression without any medication, the patient will progress. So that alpha blocker with risk of progression sometimes is not good enough. Sometimes combination therapy is very important if we find that there's a risk of BPH progression. So that combination therapy or the 5-alpha reductase inhibitors can help to decrease or slow down the risk of progression and also the needs for long-term treatment, particularly surgery. So combination therapy is very important, particularly for those patients with a large prostate volume, more than 30 ml. You can also consider 5-alpha reductase or combination therapy if there's also have severe voiding symptoms. For PSA, sometimes it's also very good parameter to rule out prostate cancer. And for those patients with 5-alpha reductase inhibitors, sometimes we need to take into account, particularly after 6 months of treatment. So before you start the procedure, sometimes we have the baseline of the PSA so that you can monitor 6 months later. If there's any elevated PSA, sometimes we need to consider any possibility of the PSA associated with the prostate cancer apart from the pitch. And for the sexual dysfunction, usually the sexual function is usually start with the first time new onset. It seldomly start with after 6 months of the 5-hour reductation inhibitors. So apart from that, for the resume procedure is one of the good treatment modality for the local treatment, and also endoscopic enucleation is one of the good alternatives as compared with conventional TURP. At the same time, they also can treat the median loop. For the resume case, we can have office base under the local anesthesia. They share the similar symptoms and urine flow. However, there's more study required for the long-term efficacy as compared with the conventional TRP. The good news is this novel treatment can preserve the erectile function, integrate ejaculation, and also urinary continence after the procedure as compared with the conventional TRP. For the chronic prostatitis, after the diagnosis, like damage assessed, culture-guided antibiotic treatment are very important. And the EU guideline also suggests a culture guided with different duration. So this is the end of my presentation, and thank you very much for your attention. And I welcome all of you to have any question. I will answer all of you.
Covered almost all the relevant points in the surgical management of BPH as well as the medical management. We all know that this is a wide topic, and you have very good experience in that, and that mastery is well proved in your talk. Thank you very much. Now
Thank
we
you.
have a few questions from the audience and a few from my part also, so that we will have a better discussion on the subject. The first question was, see, we have enumerated numerous treatment modalities, medical managements, and other things. Do you want to follow a particular guideline, or do you follow a particular guideline in the management of a BPH? Is it we have so many guidelines available, like AUA guidelines, EAU guidelines, and some countries, I mean, Canadian people have their own guidelines. So do you mean to say that since it is a very common disease and a lot of people are treating it, do we need to have a guideline, and if at all, what is your suggestion?
Thanks for the question. Actually, it's a very good question, because I think that the guidelines is very important. I myself and also my colleagues in Hong Kong usually follow the EAU guidelines with supplement with the AU guidelines. You can see that both guidelines is worldwide with formulated by a very large group of experts. And also AUA and also EU guideline also share very similar diagnosis treatment steps. So usually, even in our preparation of the presentation and also my practice and daily clinical services, I usually follow the EU guidelines. But I think that it depends on your policy and also the experience of your hospitals. I think EU or AU guidelines are very good guidelines for you to follow.
Okay. In Indian setting, the Urological Society of India is actually formulating their own guidelines, our own guidelines, for which will be useful for the people of the Indian subcontinent, and hopefully it will be released in the coming year.
That's great.
Now coming to see, you have clearly demonstrated the beauty of bipolar enucleation of the prostate. Now, a few of our audience are happy to know whether you will consider a laser enucleation or a bipolar enucleation, and if you are opting for one of this, why?
Okay, that's a very good question again. I have started the whole lab and also bipolar lab together. I think that both of them have advantages and disadvantages. Firstly, for the whole lab itself, there's a lot of data showing that efficacy as compared to bipolar lab. It's a very long history. So many of us will start with the whole lab. However, the whole lab is still is a very long, steeper learning curve as compared to bipolar, probably because you can see that we use the same instrument of the TRP during the bipolar lab. It's totally different from that of whole lab. We have a different instrument as compared to conventional TRP. At the same time, you can see that the learning curve is longer in the whole lab. And you can see that the electricity plug supply of the whole lab is different from that of bipolar lab. So that you make sure that your operation theater will have supplied this kind of high power electricity plug, so that not all the operation theater can support this laser integration. Well, I think that bipolar lab itself, for me, I favor over this bipolar lab because you can see that if you have any difficulty of bipolar lab during this procedure, you can just convert into the conventional TRP. As compared with whole lab, you need to change back to the instrument of the TRP. Sometimes it takes a long time because there's not very easy availability of the TRP set. But at the same time, you can see that I usually use the CowStores one, which is a thick loop, the latest version of the Autocom 3. There's a very large thick loop. The surface area is very big, so that the hemostasis I think is much better as compared to whole lab. But I think it depends on the availability of the instrument. Both of them I experienced is the efficacy in short and the midterm are quite similar in our series.
Okay, thank you. Now we have two more issues coming up. One, when you compare HOLUP and bipolar, what about the incontinence rate? Because we know that incontinence rates are incontinence is there as a complication in HOLUP as well as in bipolar, at least to some extent. So how do you compare? Which is having a better result?
Yes. Actually, for whole lab itself is less blunt dissection as compared with bipolar lab. Bipolar lab sometimes you need to have the tip of the receptoscope, so that it's kind of more or less a blunt dissection and sharp dissection. However, the whole lab itself is mainly kind of laser ablation and also develop the plane without much blunt dissection. So theoretically, there's a better continence control in the whole lab group. However, as you can see my video, I particularly focus on the sphincter preservation with the early apical mucosal incision, and then later back I go back to anterior soma again, and also particular preserve the apical mucosa together a little bit of those apical loop. So in our series, also compare with the incontinence rate of the whole lab and also bipolar lab, so that is only around 2% of both cases. There's no significant difference between the bipolar and the whole lab. Probably because we have a lot of precaution over the UFO protection, UFO sphincter protection during bipolar. So I think more or less are similar in the continence rate.
Okay. Now, one more issue regarding this. When you are doing a bipolar, in many of the models available, they have a separate instrument for a bipolar rather than the bipolar TURP. They have a separate instrument where you have a separate type of loop and all. So do we need to have that particular instrument, or even with a common bipolar TRP you can do that? That is question number one. And I think you can we can discuss one more question along with this. See, it is possible with the bipolar TRP, then why don't we think about doing a enucleation of the prostate with a monopolar TRP?
Okay, very good. So firstly, I start with bipolar using conventional receptor loop, because I start with Olympus one with the conventional loop, and also I start with the conventional CowStore loop, which is not a thick loop. I personally find that they can start with this kind of loop, especially when your hospital do not have thick loop. Both of them can start with bipolar because they also have a very good hemostasis effect. What I want to mention is that the thick loop is better in terms of hemostasis, but it's still possible using the conventional TRP set to start with the enucleation. So you can start any time you want. And for the monopolar TRP set to do the enucleation, I personally don't agree with that, because you know that enucleation time, especially when there's a start with the learning curve, it will take longer time. Let's say it's more than 1.5 hours. There will be the risk of the tear-off syndrome. So I think that the monopolar TR set is for the indication, I think is a little bit dangerous, especially for a large prostate. So I don't recommend this for the indication.
Okay, but this was a question from the one of the members who attended our meeting. So you have clearly described why it should not be done.
Yes.
And next thing is regarding the resume, which is a which seems to be very promising, and I think I am seeing for the first time, because you have a lot of experience in introducing this and practicing it. So when I was observing that technique, the first thing which struck to my mind was you are putting some steam into the prostate. And how are you going to control the temperature? Because you have the rectum just behind the prostate, and you are not sure about the transmission of heat into the rectal mucosa. So how are you going to control the temperature transmitted to the rectal lumen?
Okay, very good question. Actually, it's very important to make sure that you have a correct injection of the needle. The video already shown that there's a small needle which can inject through the mucosa down into the prostate loop. And also with the spheroid is a kind of water vapor which takes time for the prostate necrosis. So it's very important to make sure there's no leakage of the water vapor to the mucosa. So during the cycle, you need to have kind of some firm compression of the needle deep into the prostate gland. Otherwise, if there's no constant pressure with this needle, there will be the risk of the water vapor leakage. Sometimes, if there is very severe leakage, there will be the damage of the urethra and the causing stricture. So that's why during the procedure, we need to have maintain a very static movement of the patient. The patient cannot move. At the same time, you need to place the delivery device firmly over the mucosa of the prostate to make sure the 9-second cycle of the water vapor can be delivered into the prostate gland so that the water vapor can diffuse through the gland without leaking into the mucosa. So this is my trick.
Okay. So now coming to the second part of our discussion regarding chronic prostatitis. Uh, See, many of us know that it is not very comfortable to treat chronic prostatitis, at least in some other situations.
Yes.
So, do you have a magic choice of drugs which is helping your patients, at least in your experience? What will be your combination of drugs, or what will be your recommendation?
Yes. Firstly, we need to make sure that to differentiate whether there's a diagnosis of other possibility like BPH, prostate cancer. Once you confirm diagnosis, this is chronic prostatitis. The second step is to rule out a bacterial type and non-bacterial type. So that's why the STEMIS test is very important. Once you confirm there's the bacteria, you need to start with antibiotic immediately with the exact duration recommended by the EU guidelines to make sure there's a coverage of the bacteria infection of the chronic prostatitis. So that have I mentioned in the presentation. And apart from that, I totally agree with you that the combination therapy is also very important. Apart from the antibiotic, according to the sensitivity of the culture, we need to give some support, particularly the patient complain a lot of pain. Sometimes we also consult the pain team in Hong Kong to make sure that the patient have pain-free during the treatment of the antibiotic. At the same time, I think the psychological support for the patient is also very important. This group of patients sometimes it take a long time of treatment. Maybe some of them have low mood or even have gone into the depression. Some of the cases, however, have need to consult a psychologist. So we need to give some psychological support. At the same time, for analgesic, we can start with first line with NSAID or any other treatment like opioid group of analgesic, but depends on the side effects. Apart from that, some of them have some warning symptoms. I also give some alpha blocker to this group of patient. The patient just comment that improve the boarding symptoms, especially the boarding symptoms. So I think combination therapy depends on the which kind of symptom predominant. But I think we need to deal with the infection first.
Okay, I agree totally, completely to your point. But at the same time, there is another problem during our treatment. But many of the patients will come with a negative culture of the prostatic secretion or the urine. So in such culture negative patients with a chronic prostatitis, what will you do?
Oh yes. So apart from that, usually this group of patients come the symptoms on and off. So I usually follow up this patient as around 3 months duration. Sometimes we just tell you that there's a symptom-free period. However, we just prescribe those with a group of medication, just give them in the kind of PRN manner if necessary. So it's very lucky that not all the symptoms persist with time. It depends on some psychological stress, pressure, and also his personality. So I think we need to treat as a whole, not only the symptom itself. You know that the chronic prostatitis usually is pain. We can just simply give a group of analgesics and store at home and prescribe it if necessary. But we need to deal with the psychological component also. There will be a lot of anxiety. We need to deal with that, not only treat their symptoms. So I think that apart from antibiotic for the bacterial type, non-bacterial type sometimes even more difficult to treat, especially there's a lot of symptoms. So bear in mind that multidisciplinary approach is also important for this group of patient, including psychological referral and also with pain team consultation. At the same time, we need to give adequate analgesic and also psychological support for this group of patient.
Are you commonly using alpha blockers, or in case you are using alpha blockers, what type of alpha blockers will you prefer in a patient with a chronic prostatitis?
Yeah, I quite commonly give the alpha blocker to this group of patients because usually they will kind of problem avoiding. If there's some pain, they will associate with some warning symptoms. I usually the first line is to give Cetral, because in Hong Kong nowadays we seldom give minipress, tyrosine, hydrate, because you know that there's a problem of hypertension, dizziness, and malaise. Especially for those patients chronic prostatitis, the patient may be a young age of group, do not have any hypertension. Sometimes we cause them hypertension, we get the symptom get worse. So I usually give a more patent drugs with less side effect, including Cetral, or even I give 100 orcus to this group of patients, so that I try best to give a more better drugs, so that to give less symptoms side effects. At the same time, I also give a group of patients with some storage symptom. You can know that the patient will have urgency and frequency. So I also give some anticholinergic to this group of patient. Something works, especially if the patient have a storage symptom predominantly.
Okay, one of our delegates is happy to know about the differences you feel uh, in the results and methods and complications of bipolar and monopolar TRP.
Okay, you mean the difference of the complication, right?
Complications.
Okay. For the monopolar one, which well known is TRL syndrome, but after turning the bipolar TRLP or bipolar lab, the symptom of the TRL syndrome already disappear. So I think it's a good news for the disappearance of the TRL syndrome during the monopolar TRLP. And for the EU guideline, it found that the complication between the TRP and also bipolar is more or less similar. However, for the efficacy of the prostate resected for the bipolar or endoscopic education is much more as compared to TRL. But the time, especially for the learning curve, it will be a little bit longer as compared with bipolar. TRP. So for the complication, I think that because you know that the hemostasis is better, so the length of stay, the capital time, and also the drop of hemoglobin is lower as compared with the bipolar TRP. So it is already confirmed by many studies.
Okay. And one more problem regarding chronic prostatitis. Suppose you have a patient who has a history of recurrence of chronic bacterial prostatitis, and later on, by around 50 years of age, he's having a reasonably enlarged prostate, say 40 or 50 grams of prostate, and he's having obstructive symptoms also. How comfortable you are in offering TRP to such a patient who has a history of recurrence of the chronic bacterial prostatitis and a BPH?
Okay. Yes, that's very good questions. I think this is very important to differentiate the diagnosis first, because you know that for TRP in the chronic prostatitis patient, you will not have any helpful condition. So I think a urodynamic study in this situation is the best treatment between this differentiation of the PBH and also chronic prostatitis. You know that the PBH in the urodynamic, you can show there's a POO I index. There is if there's any obstruction, better outer obstruction, the index show is 40 more. However, in chronic prostatitis, sometimes it's non-obstructive one. You just only have POI is less than 20 that I mentioned. So in this case, I will do the urodynamic. If I found that there's POO, so I will think that the TRP will have the benefit to this group of patient. However, if there's urodynamic confirmed there's no obstruction, I think TRP may not have this group of patient. So I will just reassure the patient, educate the patient, and also give the maximum medical support instead of the surgery for those patients. Confirm there's no obstruction in the urodynamic study.
Now we have Dr. Shivam Priyadarshi, who is a professor of urology in the Jaipur Medical College. He has put a very tricky questions to you. Suppose you have a prostatitis patient, chronic prostatitis patient, and refractory to all your management. Do you consider TRP at any stage of the management of a chronic prostatitis?
I think I just will not very just empirical give the TRP to this group patient. I will just give a lot of investigation. Just I mentioned I will give the urodynamic first. At the same time, I will have make sure there's obstruction first, because you know that there's some complication of TRP. Sometimes we'll also have erectile dysfunction, retrograde ejaculation, and also with incontinence. Sometimes, if the symptoms or complication we have this group of patients, they will have even worse mood or say depression if there's a wrong diagnosis and wrong treatment for this group of patients. So I would just do the urodynamic despite the medication. If I just do not confirm any PO, I will not do therapy for them.
I think there are no more questions from the audience. Thanks, Dr. Low, for that wonderful talk and the beautiful interaction. You have really enlightened us in many points, especially the newer techniques you have mentioned. I think there will be a lot of followers in India also, and you will be having a lot of queries. And we look forward to your activities in the Asian Prostate Federation also. You can have a lot of members from our group, and SASSM will also be happy in having you in future discussions regarding BPH and prostatitis. And please be with us in future meetings also. And we are really thankful for your sparing this much time with us. And you have spoken to us for nearly 1.5 hours. Once again, I thank you on behalf of SASSM and all the delegates and Docplexus. Thank you.
Thank you. Thank you for invitation and also very good arrangement. So it's my also very good honor today to share our experience and a very good response and also very good discussion about this topic, PBH and also prostatitis. Because of the COVID-19, we cannot see it physically. Hopefully, after COVID-19, we can have kind of sharing and also meeting together.
Thank you, Dr. Low, and thank you, Dr. Thank you, sir. So thanks for sparing all your valuable time with us for moderating session, and thank you, Dr. Low, again for sharing all those advanced inputs And also we thank Docplexus for supporting us on the back end. And also like we thank all our viewers for supporting across the world. So we'll be again meeting you all with the next session on 27th. This time like, it's going to be andrology and obesity by Dr. Giovanni Corona. Same 6 o'clock Indian Standard Time. Thank you, everyone. See you.
Okay. See you.
Thank
Bye-bye.
you.